Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
Hey, what's up? Welcome to episode 7 of the Civilian Medical Podcast. I'm Dietrich, Skinny Medic, and I have my co-host Sean Heron here, and we make up the Civilian Medical Podcast.
We are the guys that do it.
Bless our hearts.
We couldn't con anyone else into doing it, so we had to do it ourselves.
I know you barely talked me into doing it. Wore me down.
I know I did. It was a very long process, and I actually tell that story pretty often. I'm like, yeah, you think that I won't keep after something? Just ask Dietrich.
That's what I told her. I was like, it's a very long courtship, but we're good now.
But it's a great relationship so far. Hey man, we're going to be at the NRA, and actually this show is going to come out on the day that everyone kind of starts to head down there. So if you're listening to it there, give yourself a high five. Wait a minute, keep your hands on the wheel. Don't give yourself a high five. That would be dangerous.
Don't wreck.
But Saturday night, April 27th, we are having a Firearms Radio Network listener meetup. It's going to be at Sun King Brewery, which is just about a little bit over a mile away from the convention center. So it's a, quick Uber, whatever you want to take. It's going to be a blast. There's going to be a bunch of different shows from Firearms Radio Network that'll be there. Lots of sponsors, some giveaways. I even heard that Medical Gear Outfitters and Skinny Medic was going to give away some med kits.
Yes, that's the rumor on the street, is that I'm going to be there. My wife's going to be there. So you can at least come see her. She's much better looking than I am. But yeah, we're giving away 3 medical kits. We're going to give away our Skinny Medic Essentials kit. We're going to give away a Skinny Medic Pocket kit, and then a Skinny Medic Small First Aid kit. So we'll have 3 kits we'll give away. And plus we'll have stickers and patches and stuff like that there too. So
very cool. And again, that is at Sun King Brewery, April 27th, 6:30 p.m. Can't wait to see you all there. We have covered just about everything in the March thing so far. We've covered our 3 phases of care, and we've covered massive bleeding, airway, respiration, circulation, and we're moving on to H today. So in the March algorithm, which I still defend calling it, or people say, no, it's an acronym, not an algorithm. And then, I think I even mentioned this last week, but apparently I'm pretty sensitive about it.
Oh yeah, that's going to get some comments there.
I know, I love it. So what does H stand for?
So H stands for head injuries and heat loss, which was kind of, as I was we were talking about before, doing the notes for this. I mean, we can dig so deep into this and still just kind of skim the surfaces.
Yeah, I do 100% agree with that. So, I mean, let's start with head injuries. First off, how does one get a head injury?
So this is going to be a traumatic event. Maybe the patient falls. Maybe they were involved in a MVA or a car accident. They hit their head. They fall from a height. Basically, you can obviously get it from a standing position, but more typically we're going to see it. Their feet are off the ground. Maybe they're on a ladder or something like that, and they fall, and then they injure their head, and they're going to have some sort of trauma to the brain.
Yeah, and that can manifest in a ton of different ways. So if we don't actually see the injury, we kind of have to make assessments based on the mechanism of injury. But how do you diagnose a head injury kind of just on the street, on a sidewalk, at a mall, whatever it happens to be?
So like you were saying, the first thing I would do is I'd make sure the scene was safe for us, and then kind of look at the mechanism. What happened? Did they get hit by a car? Did they fall off the building? Look around. Did they fall onto the grass? Did they fall onto the concrete? How they land. That's all some kind of evidence to kind of start building our story to what's going on. And then, we're going to put our hands on the patient, kind of see what's going on. Do we see some blood coming from the head? Do we feel a hematoma? Do we feel kind of like a crepitus, which is kind of like a crunching feeling? That's always bad on the head.
And what's a hematoma for those that don't know?
So a hematoma is going to be like a bump on the head that we're going to see it. You're going to be able to feel it like a big knot. You're going to be able to feel it with your hands there.
All right. So hematomas, crepituses. What else?
We kind of start talking to the patient. That's one thing, I always tell people you should introduce yourself to the patient, to give them your name, and generally try to ask if you can help them. And then kind of find out what their name is. Do they know what day of the week it is. Do they know who the president of the United States is probably a good general one. I will ask, if it's near a major holiday, like, hey, what holiday's coming up? Kind of start filling out, because especially if you're talking to an older person or, someone who owns their own business, they may not have any idea what day of the week is. They just know they're supposed to go to work or whatever. So, so you just kind of have to play that one by ear. But checking their mental status is a huge way to figure out if someone possibly may have a head injury.
Yeah, definitely. Because if they can't answer who the president is, well, I mean, a lot of people are in denial these days, but you never know.
Yeah, like that's going to get a response either way. I feel like for the last 12 years, it seems like when you
Yes.
ask who the president is, you get like that SOB, and you're like, okay, what is he? Like, so, people either love or hate him on both sides the last 12 years, seems like. So, it gets you a good response.
Yeah, 100%. So, I mean, altered mental status is kind of a big deal. It's just someone who's not acting right. And I think we've covered it a bit in previous episodes, but it bears going here again because head injuries, traumatic brain injuries, these heavily, they're head injuries. They lead to altered mental status.
Yeah, and like you said, there's a bunch of things that cause this altered mental status, and we could do a complete show on just altered mental status, which we probably will in the future, just talking about what causes this. But in the event that we're doing the March algorithm, obviously the patient has some trauma, which is why we're going down that rhythm or acronym. Then we could kind of start saying something's not adding up right, and this could be a simple concussion or it could be a head bleed. We don't really know what's going on until they get a CT scan of the head and figure out how bad it is or how good it actually is.
I chose to be involved in a single car accident where the guy had altered mental status. And I think I've actually mentioned on the show, the guy with the pillow rolling across the street. And, it really made me pause whether I, as a just civilian, driving down the road, witnessed something, whether I wanted to just be involved at all. It really made me pause because he was clearly agitated. He had had a one-car injury and somehow ended up outside his vehicle as it went and crashed into a curb and an electric box. And he was definitely showing signs. He was angry because some lady was dialing 911. And, I didn't know what was wrong with him as far as what caused the altered mental status. Could have been head injury, but it was more likely drugs or alcohol or something like that. But I really made a conscious effort to decide whether I wanted to work with him. Why is it dangerous to work with somebody who has an altered mental status?
You can take the sweetest little old lady or old man and something starts happening, whether it be a head injury or, diabetes starts happening, and they are violent. They're cussing like a sailor, and, they can completely flip them around. And so you've got to kind of be cautious with these people. That's why I put then in my notes that I always, for someone who's altered mental status, I will always double check and make sure that they're not armed. Maybe it's just a quick sweep across the waistband or the ankle, because if you do have someone and they're not fully aware of what their actions are, then I want to make it a fair fight. That way, if they're going to start fighting, they're going to start swinging, that at least they're not drawing a knife on me, drawing a gun on me. So I always just double quick check these patients, even if it's just a medical reason why they're altered mental status, just to make sure. And then when they get their senses back and they're back awake, then they can have their toys back. But for right now, we're going to take their guns from them or take their weapons from them.
How do you, have you had to do that like actually in the field or mostly exercises like me?
Yes, I have to do it a couple times. I can think of a couple car wrecks I've done it on. One was a little old man. He had like a pretty cool Smith & Wesson revolver. Like it was nickel plated. Like it was pretty. And me and the cop made a joke about like how pretty this old man's got his pretty gun in his waistband. But he was a diabetic. He'd run off the road and kind of didn't really have any injuries, but he was altered. I'm like, I don't figure out what's going on. He didn't know what day of the week it was. He was pouring sweat. So we checked his sugar and it was super low. So while I was down there, just kind of double checked. I was like, hey, this guy's got a gun on him. So we took it off and gave him some medicine, brought his blood sugar back up, and he was fine. We gave his toy back to him. We talked about the gun. So kind of have a conversation about how cool it was.
Yeah.
But, it's just kind of that safety. I've got an older man who was he was a veteran. So if I start pulling and tugging on him, I don't want him to go back to the days where he was in the trenches or wherever he was at and wanting to start fighting. And that way he draws his gun. And now we've got a big problem. So I've been drawn down before, never been shot at, but had a gun pulled on me a couple of times while I was, full-time EMS, and that is not the best feeling in the world. So
no.
So, when you're assessing these patients, that's kind of things, just another tool in the toolbox is to just do a quick exam, make sure you're not missing anything like a weapon.
Having really good de-escalation skills, because I mean, uh, generally, I think people want to be helped, but if their altered mental status or something like that, the guy with the pillow that I was just talking about, I scanned his waistband. I looked in his front pockets to see if I saw any knife clips or anything like that. And then I made a conscious decision that, yes, I'm going to put my gloves on and help you. But up to that point, it wasn't a given, man. Go back to my car, call 911. I'm not looking to be shot at, stabbed, scratched, or bitten by somebody who has an altered mental status. Like, I'm not on an ambulance. I'm not riding on a rig. I'm literally just a dude driving his car down the road that saw something bad happen and wanted to help. And my life, to me, my life is more important than someone who should wish to take it.
Right, and one of the best fights I remember being in EMS to this day was a diabetic guy. We were wearing the backpack EMS style first aid bags and walked around the house, down the hallway to his bedroom. As soon as I come around the bedroom, he tackled me, and so now like a turtle with this huge backpack on, I'm trying to get the backpack off. This dude is sweating. He's bigger than me. He wants to fight, and so we fought for a few minutes till I could get some more help there and get up off the ground, but ended up we got his blood sugar back up to normal, and he was so apologetic. He was like, I apologize. He didn't remember a dang thing that happened, and he had blood all over him, and he had to go to the hospital because of his injuries for that. But that's he had no idea what he was doing. So you feel bad for him when they wake up, but during the time, like you said, your safety has got to be important.
Yeah, I noticed that little humble brag you threw there, that he had to go to the hospital from his injuries from your fight.
Yes, I did not have any injuries. He had to go to the hospital for his injuries. But yeah, so it was one of those stories I always remember. Like, I always tell my MT class stuff like that. So, but yeah, I was fine. I was good, and he was bigger than me, so I like to fight, so it's fine.
That's amazing. I love it. All right, so altered mental status, big deal. Disarming is a super big deal. As civilians, it's a little bit hard. We don't have that professional authority over somebody. Like, people see someone in a uniform, and I think they trust them generally, and maybe in that case, clearly not. But in general, I think they see you in a uniform and they give you a little bit of respect, or at least most people do, right?
Right, and like I said, that may be some of the civilians. You guys need to get law enforcement involved. You pulled over, like you said, that car wreck. Like, this guy's not acting right. Maybe you do have to stand back until the cops get there and like, hey, officer, I'm a civilian. I've got some medical training, but he seems like his elevator's not going to the top. And maybe get law enforcement to kind of step in there and help you disarm him or double check, and then you can start providing care, because not all cops have medical training. So they may actually welcome you to do some medical while you're waiting on fire or waiting on EMS to get there.
All right. So what's next?
So while we're talking about trauma to the head, we can still start assessing our patient, kind of figure out what's going on. And some of the other kind of signs and symptoms can be, if they're super dizzy, they're unsteady on their feet, we could maybe possibly have a head injury. Memory loss, there's another one. When you start asking, getting repetitive questioning, you ask the patient, hey, I want you to remember the color yellow. And maybe 2 minutes later go, hey, what was that color? And they don't remember it. Or they're asking repetitive questions like, what happened to me? Where am I at? I've had moms say, where's my kid at? And we've looked like we hit panic mode. And there's a car seat back there, but they dropped their kid off 2 hours ago. They just don't remember it. But now they're worried about their kid. So they'll ask you 1,000 times, the same question over and over and over again. And it's just a block there in their mind for that moment in time. The other thing we talk about is these patients, especially with severe head injuries or even some concussions, can lead to it. These patients get nauseated and they start vomiting. So we talked about the recovery position a few episodes ago, and this is a great time to put someone in recovery position, because if they start vomiting, maybe we don't have a suction device, but they can, depending on how severe the bleed is, they can have projectile vomiting, which is vomit just flying across the room or flying across the road, and it's super nasty. I don't want to be caught in it. I'm a sympathetic puker. So that's something to be aware of. And if you do have a patient that you're like, I think this guy has a head injury, go ahead and get prepared for that vomiting, and kind of, that way it doesn't surprise you.
Yeah, definitely. And recovery, you can find that in the episode that we talked about airway. And I think we also talked about indirect threat in that episode.
Believe so.
All right. So yeah, nausea, memory loss, dizziness, trauma to head. It sounds like me every day.
Yeah, exactly. Me before I get 2 cups of coffee in.
Yes. Now this next one, this is me every day. Feeling tired.
Yes, feeling tired. This is me, but like on 1 cup of coffee. I'm like, "God, I just need more coffee." And then I need my 3 o'clock afternoon coffee cup too. But yeah, feeling tired, just wanting to go to sleep. And, like long time ago, they were like, "Oh, you got to keep the kid awake." They still kind of talk about a little bit. If your kid's got a head injury, like, don't let them go to sleep. But just that feeling of wanting to go to sleep, we need to kind of keep an eye on it and just be aware of it might possibly be a head injury.
Yeah. So do we let him go to sleep or not?
I try to keep them awake just for a little bit, just to see what's going on, especially if you start getting some nausea, vomiting, and stuff like that. But I do try to keep them awake just for a little bit of time.
All right, makes a lot of sense to me. Sensitivity to light or noise.
Yeah, and just it kind of depends on where the injury at is in the brain, and it can affect different things. And some of the things it can be is, there's just a bright lights, maybe the strobe lights of the ambulance or the fire truck are really bothering them. It can even lead to them having seizures. But that's more the extreme case. But they can have some light sensitivity and noise, loud noises, kind of like you've had a hangover. It's kind of the same thing they're going through.
Yeah. And then one of the real precursors that I'm like, okay, this person is in serious distress and needs to get the next level of care ASAP is unequal pupils. If you look at light and one's bigger than the other one, it can also be diabetes. Diabetes can cause that. But yeah, unequal pupils, it's a late sign and very, very concerning.
It is, that's one of the things we tend to focus on and think about. But that is it's part of an exam. You don't need like your 50,000 lumen LED, pocket light to check this. This is just a simple pin light. Maybe you cover their eyes up and do a kind of a reverse move on it. If you shine a light in there, it's going to restrict. It's supposed to, it should. But if you cover them up with your hands or make them close their eyes just for a few seconds, then the pupil should dilate. And then when they open back up, it'll constrict back down. So you can kind of do it reverse if you need to, if you've got lights around you and you don't have a flashlight.
Yeah, it's definitely a concern if you see that. And visual acuity testing doesn't need to be like real in depth or anything like that. Like you said, just cover their eyes, take your hands off, look at the response of the pupil, and kind of make assessments there. One thing to bring up here is that a lot of these signs and symptoms, they can be very, very similar to signs of shock, and even, as we'll find out soon, hypothermia and heat loss. So we really need to kind of be able to figure out, are these signs of altered mental status or a head injury? Are they signs of shock? And what would you say is kind of some of the easiest ways to do those things?
We can do vital signs. That's going to kind of tell us, we talked about that around the circulation
Mhm.
part of the March algorithm is doing a pulse check, doing a blood pressure, kind of getting that baseline check of, what's going on. And EMS, when they get there, they've got a few more tools in the toolbox they can bring to kind of check some things. And then when we get to the hospital, they have more tools. So it's kind of like us as civilians, we've got a little bitty toolbox. EMS has a bigger toolbox, and then the hospital has a huge toolbox to kind of figure out and kind of weave through the symptoms and kind of figure out what's going on with these patients.
Yeah, 100%. So that brings us to concussions. Let's talk about that a bit.
Yeah, like I had a concussion when I was a kid, and they didn't really do anything about it. Like they were like, oh, okay, it's just a concussion. And now recently they've kind of figured out that they have gotten more serious, and there's still just kind of like a bruise on the brain that typically it heals. This is just a temporary problem, but it's still something that we need to be cautious about. You're still bruising the brain, which is pretty significant. The brain's not made to do that. It's padded very well. There's plenty of padding up there for the most part, except when we start getting older. When we get older, the brain shrinks just a little bit. So the brain can kind of shift back around, which kind of leads to more head injuries for like older population. But for the most part, it's padded very well. So these concussions are something that can exhibit those signs and symptoms we talked about with head injuries, but they're most likely just going to be temporary.
All right, very good. And I too had a concussion, which explains a lot of things now. I'd forgotten about that, which is memory loss. So, but yeah,
I don't remember that whole day. Like I was a kid and we were playing dodgeball, and apparently I collided with this kid like face to face, and I never remember that day. Don't remember. Like my mom was like, "Oh, okay, he's got a concussion," and like we went to Walmart, and I just kept asking repetitive questioning. So like,
funny.
great mom.
Mine, mine was I was in a car unseat belted because, man, We didn't wear seatbelts back then. We didn't care. And got into a head-on collision and hit my head hard on the windshield, like broke the windshield with my head. And if
Oh,
what I know today of how I have literally tried to break some windshields and it was really difficult. So knowing that I broke it with my head back then, it was tough. Didn't go to the hospital, but definitely had a concussion. Went to the doctor like, I don't know, a day later when I was still experiencing blinding cranial pain.
oh.
Yeah, it sucked. I vividly remember the pain. I don't really remember anything after that.
They've gotten more and more, especially like football players, stuff like that. Like concussions are kind of like the front line now. There's a lot of research going into them, a lot of data being pulled from them about how they can. We get one concussion, you're more likely to get another one. So just you only get one brain, so we need to take care of it.
Yeah, 100%. The National Hockey League has a bunch of concussion protocols. If they see something, they've got some quick diagnostic tests that they run, and they literally will just pull them out of the game if there's signs of concussion. And it's because so many football players and hockey players have died later, not even much later, but right after their career, but clearly still in the prime of their life because of those brain injuries, those repetitive brain injuries.
Affecting motor function, how they can move their arms and legs. Like it is a big deal. Now we just didn't know, and we weren't very well educated on it even just a few years ago.
Yep. In bad cases, we've got some bleeding on the brain.
Yeah, we've got like kind of the concussions. That's kind of the mild head injury, which is if you're gonna get one, that's probably one I would pick. But then you can actually get that's just a bruise onto the brain, and you can actually get some bleeding that occurs depending on what area of the brain it is, depending on how fast or slow it is. But this is something that maybe they have to go and do surgery on to get it to stop. Maybe it corrects itself, but can definitely cause some major problems. Those slow bleeds are typically in like the subdural part of the brain, where the padding is on the brain. It's very arterial. The scalp is, the brain is. There's a lot of blood flow there. The brain requires a lot of oxygen, requires a lot of sugar, so it needs all that to function. And so these slow bleeds are the ones I tried to find who the actor was, but there was an actor, husband, too long ago, who was snow skiing, hit her head, and then 3 days later she was dead. And I couldn't find the name of her, but that was a subdural bleed. That's a slow bleed. She hits her head, or the patient hits their head. They seem fine. Maybe they have some dizziness, some headaches, something mild going on, and then 3 days later they're dead.
Wasn't that Liam Neeson's what, Natasha Richardson, or?
That sounds familiar.
I think that was it. I think that was Liam Neeson's wife, maybe.
That sounds right. But I just remember she was skiing and hit her head, and then bam, like 3 days later she was, and she was not good. And I've had patients like that. Maybe they're on blood thinners. Like I said earlier, that typically patients over 65, we start to kind of lose some of our bone density, start losing some things. And so those brains are not as padded as they used to be. Our heads are solid. There's plenty of padding. The brain doesn't move around. But then as we get older, there's less padding. So the brain kind of shifts a little bit. So maybe grandma falls in the kitchen and hits her head, and she's on blood thinner. She takes aspirin or something else. And then, she complains of a headache. She doesn't want to call you because she doesn't want you to worry about her. And then, 3 or 4 days later, she has a severe head injury. And by that time, it may be too late. So the other ones are these quick bleeds, and they're the subdurals are usually like venous bleeds. They're slow bleed, and epidural bleeds are arterial, and they're fast. This is where the patient hits, and then boom, they're unconscious. And maybe they're posturing, which is their arms can even pull into the spine, or they flex out. The toes do the same thing. But that's a severe head injury, and that's bad news quick.
Yeah, 100%. All right, so let's bring this back now. Civilian medics, guys that are out there with IFAKs in their cars and backpacks and go bags and things like that. What can we do about head injury? And the answer is not a whole lot. We just have to kind of figure out if we think that they have it, and then really turn it over to that next level of care. What are your thoughts on that?
Exactly. I mean, we gave you a ton of information that unfortunately you can't do very much about.
Right.
But at least you're educated about what's going on.
Yeah.
The biggest thing I would say was we watch out for that vomiting. Watch out for the projectile vomiting. You don't want to get vomit on your nice clean shirt. And that being disarmed, kind of being aware that this guy's not quite acting right. And if maybe you help a law enforcement, or maybe you help some buddies, but you make sure he doesn't have a weapon on to protect yourself.
Yeah, 100% agree. Okay, so in that H, we also cover that heat loss or hypothermia. Why don't you start us off on that path?
Yeah, so you've got your IFAC, you've got your first aid kit, and you spent good money on it, and something happens, and you use some equipment out of it. Let's say, for instance, you use a cat tourniquet, you use a halo chest seal. You really like this guy. You use some combat gauze. You use your Elias pressure bandage. You've got $150 worth of supplies you've used on this guy because you really like him, and the $2 Mylar space blanket is what's going to ultimately save this guy's life after you've done all the cool, sexy trauma stuff. You've done all this stuff, you've worked your butt off, and then you're leaving him laying in the street when it's 65 degrees and his body temperature starts to drop, and he's getting hypothermic to his core body, and his body can't clot anymore, and he's dying. And you're thinking you did a great job.
Yeah. Or realizing that something else is wrong and you just have no what, because you're like, I did all the cool stuff. I even used my $45 combat gauze, and but he's still crashing and going downhill in the wrong direction. And yeah, hypothermia is a big deal. And one of the big reasons that it's even in the TCCC and TECC protocols is literally because we had people in the desert, going hypothermic and becoming way more critical, even though it's 140 degrees out and they're wearing full battle kit and everything else.
Exactly. If you ever get a chance to go into a trauma center, go into a trauma bay, it is hot. If you're wearing t-shirts and whatever, and you just start pouring sweat when you roll in there because they have the heat jacked up all the way up. When I teach EMT classes, paramedic classes, I'm like, when you get these trauma patients, when you get out of your ambulance, you should turn the heat on. And they don't really like to do that. Paramedics don't like to sweat, but that's a real issue. And even in the summertime, if I'm working EMS, I'm gonna have 4 or 5 blankets tucked away on the stretcher just in case that I get that trauma patient. I need to keep them warm.
Yeah, 100%. So what is the lethal triad?
So the lethal triad is part of the hypothermia. It's kind of combining of acidosis, way the body clots, and hypothermia, which is leading to death. And this is one of the leading causes of death in patients once we get all like the airway, breathing, circulation taken care of. So it's just a combination of all three. It makes a pretty cool triangle. Acidotic, this is going to be a lower than normal pH due to increased hydrogen ion concentration. So the body wants to stay between 7.35 and 7.45 pH, which I know we're talking way above even my head, like chemistry stuff. But when the body starts to get out of that pH range, it really jacks itself up. It doesn't take much to get out of that pH range, and the body starts really having trouble. Maybe clotting, maybe the heart rate causes some cardiac dysrhythmias and things like that. And then, we have this system that when we have an injury, it starts sending clots to the injury site. The body realizes there's a hole in the container, and it's like, oh, I should probably fix that before I bleed to death. So it starts sending clots, and it starts piling on clots as much as it can. It's generating clots to this site. And if the body temperature is low, then it can't do that. So now we have a hole in the container, and it's just free flowing out without any gates there to catch the blood.
Definitely. And then so that those things create that lethal triad.
Yes. So, if the body drops below 95 degrees Fahrenheit or 32 degrees Celsius, that's when our point we're going to start getting the problem with the clotting, or we get acidotic with the body. And, that can be 70 degrees outside laying in the concrete. It's going to absorb that body temperature, and it happens very quickly. We already talked about shock before. So the patient's, cool, pale, diaphoretic. So they've got, sweat on top of their body. The wind's blowing across it. That's causing the body to cool off. Maybe they're laying on concrete, which is sucking the temperature out of there. So it doesn't take very much, and the body's temperature starts to fall quickly.
Yeah. So our normal temperature as human beings is 98.6. Mild hypothermia starts at about 95. Now let's talk about some of the symptoms of mild hypothermia. Skin pale, clammy, numbness in the extremities can be signs of that. Sluggish responses.
They start to shiver a little bit.
Yeah, shivering. We all know that one and recognize that one. But even a little bit of confusion or just like really feeling tired, and we talked about that with head injury as well, but that's something that can happen with hypothermia. And occasionally, mild hypothermia will have increased heart rate and breathing and respirations. So that can be something that triggers us to look at it. Now, once we even go past that, there's we get into a lot more real physiological stuff, like they can pee their pants just because kidneys start to shut down. And this is 89-ish degrees that you kind of get down to that point. But at that point, no longer shivering, uh, slowed heart rate, and the respiratory rate is low. Also low blood pressure, and that's dangerous. They need to be warmed up. So what you'll notice is that a lot of those symptoms are very, very similar to shock. They're also similar to head injury. And again, shivering for us is kind of a key, something to trigger on. But really, take that $2 blanket at the end and put it around them. When you're kind of done working and you've gone through March and you've reassessed every single thing, and you're sure that they're breathing, they're not bleeding, and everything is good to go, put the blanket on them. Because if they've lost blood, hypothermia is a severe risk.
Yeah, I mean, you can even spend like the $5 and get the super nice blanket that, is like the blizzard blanket that's going to keep them warm. And, we talked about, maybe you take them off the ground and put something, a barrier device in between them and the ground to kind of stop that absorption, losing the heat. Um, Cover their head up. We lose a lot of heat to the top of our head. So I like wrapping blankets around their head to keep them warm. Just kind of enough where maybe I cover them up, but I leave me easy access to stick my hand in there and feel where we put that tourniquet or feel where we put the chest seal, because we don't want to forget about that kind of stuff. So, we're covering them up. You're covering them up, but don't want to forget about them either. So kind of cover them up, but leave you access to get inside the blanket to double check where your tourniquet is, make sure it hasn't, causing a problem there. Maybe you double check your chest seal or where you've wound packed. You can kind of stick your hand in there and kind of feel what's going on. But for me, like I like keeping a wool blanket in my truck. There's a wool blanket right now, and it's 80 degrees outside, but I have a wool blanket in there, so I can pull it out and use it if I need to.
Yep, good stuff. Now, one thing about covering them up is it kind of covers up their injuries, and so you need to be sure that when EMS gets there, or that next level of care, that you talk to them. They're going to do their own assessments, but still kind of talk them through like what you did. If they want to hear it, if they don't want to hear it, don't interrupt them. But know what you've done, be able to turn it over, especially in a multiple casualty situation. It might be time to document, and I'm like, just write on their forehead if you've got a marker and you've covered them up and you've moved on to another casualty, just so people can quickly look, see, okay, this is what they found in their assessment, and then react and respond accordingly.
Yeah, I mean, one of the last calls I've ran, I was off duty, and by the time the ambulance rolled up, I had the patient almost packaged, ready to go. I had put a tourniquet on, I had all the major bleeding controlled, and the crew was in my city, so they knew who I was, and they said I was smiling from ear to ear. I'm like, this is awesome! I'm so excited. I was actually getting to play, do some work. But like you said, cover them up, keep them warm. Especially on a windy day, that may be that $2 Mylar blanket maybe blowing all over the place. And now you're just working, trying to keep the blanket tucked around them. That can be a challenge in itself. But keeping them warm, but also keeping access to your intervention that you've done. And then once the EMS gets there, kind of give them a quick down and dirty report. You don't have to tell them what their favorite color is, but at least what you've done. Maybe you did put a tourniquet on. Tell them what time it was, or how long you've been there, what you noticed when there was something unusual when you first pulled up on scene. Let EMS know. You may think it's something small, insignificant, but it may be something big that leads to something different down the road.
All right, excellent stuff. Anything else on head injury or hypothermia?
Not that I can think of.
Yeah, I don't think so either. I think we covered it pretty well. And again, head injury, not much we can do as civilian medical people. And hypothermia, we're gonna, make sure that we've addressed all the bleeding and the things that would cause them to go hypothermic, and then we're gonna cover them up, and we're gonna, pray or hope really hard that next level of care gets there super, super quick. Because honestly, with a 10-minute response time, or it's so much less in a lot of places. Like if you even get to this point, you'll be lucky. A lot of times it's get the tourniquet on, or get an NPA in them and get them in a position where they can breathe, and then people show up and they take it off your hands, and that's great. If you get to this point, like clearly you've had some time to reassess, run through March and all that other stuff. And yeah, I mean, if you get bored, do more blood sweeps, document all those other things. We talked about that a lot last week. If you get bored, do these things: secondary blood sweeps and documentation, and call 911 again and figure out where they are.
Yeah, it definitely kind of depends on what part of the country you're from. If you're in more of the rural area, you may be on there. If you're on a rural country road, you may be by yourself for a while. Maybe it's a volunteer fire department. Maybe it's a volunteer EMS service. We still have those around. So, or maybe you're in the city and there's an ambulance right around the corner. It just kind of depends on what area of you're living in. So, a lot of times maybe the fire department is there right around the corner, and like you said, you're just putting a tourniquet on before they get there. Or maybe a police officer shows up and they start helping you. My wreck that I would just happen to be riding up on, there was a game warden. It was kind of funny that I was doing some work on the patient, and the game warden's like, "I watch all of your videos," and I was like, "Cool, do you want to do this?" And he was like, "No, no, 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 you got it. You're doing a great job." I'm like, "This is your chance," and he was like, "No, no, I'm good." So there's always that help, and people are willing to help. You just gotta guide them and tell them what you want them to do.
That is awesome. That's the exact opposite of what I would normally expect from people. All right, cool, man. Let's move on to product of the week. What did you pick out this week?
So we've been kind of talking about tourniquets since the beginning of our podcast, and I felt like we just kind of keep rolling through because there's still some tourniquets on the market that we can talk about. Some good ones, not so good ones. So this week is the Swat Tea Tourniquet.
Yeah, the Swat Tea. So I mean, it's a bicycle inner tube basically that's cut open and rolled flat. They're handy. They're handy. They're not my 100% favorite thing in the universe, but I can absolutely see a lot of value in them. And we talked recently about the rats tourniquet drama that had been going on, and that SWAT T is something that is similar in a lot of ways and good in a lot of ways. And I've been practicing with them a lot lately, just as a backup, and since I'll be talking about them a lot more. One-handed, they're tough.
It is tough, and I'm like, why couldn't I invented the Swat Tea? I would be on a beach somewhere drinking a beer, but
Exactly.
I'm like, it's so simple. But it definitely is kind of like the rats. Like, it has its place, like we talked about, but it also has its limitations. And I think if you understand where the SWAT T does a really good job and where it doesn't do such a good job, then that helps you make a decision about your care. And like I said, we keep talking about a toolbox, and we're building this toolbox out, and this is another item in the toolbox to have. I think the SWAT T excels on if you've got both hands free. So if you can use both hands to use it, I think it does a great job on kids. Maybe the cat soft T don't compress down in 5 inches in diameter, right? Did I say that correct? Circumference. Dadgummits.
You messed it up again.
God, we've got to erase that. I'll start over again. I got to sound like I'm perfect. But yeah, so 5 inches round. Can I say that?
I think so. Yeah. I don't know. We'll definitely find out next week.
Yes, someone will tell us.
Yes.
So the cat and the soft T will both compress down to 5 inches in a circle. Recently, the soft T was used on a 4-year-old in Texas. I saw that on their TACMED's Facebook page. They published it. So they will both compress down super small, but these little guys and gals don't necessarily need a tourniquet. If their arm is super small, a good pressure bandage will work, which is where the soft T starts coming into its golden hour, its light there, is that it makes a great pressure bandage. So it kind of double functions as a tourniquet and a pressure bandage.
Yeah. And to be clear, that's the SWAT T. You said soft T, but you meant SWAT T, right?
Yes. Sorry.
Yeah, no problem. And I agree. And like pets and dogs and things like that, good for that. And honestly, with a little bit of practice and know-how, you can put them on one-handed. So some things that the criticisms, because I went out and I was like, let me find all the criticisms and see, what people think, and then I'll form my own opinion after doing some testing. So can I put it on my arm one-handed? Yeah, absolutely. I just literally take one piece and put it in my mouth, wrap it around and get it started. And then I can do it easily there. Tying it off one-handed is incredibly difficult. I grab something off the ground, like a water bottle or something, wrap it around one time, and then tuck it under and then pull that thing out, and it'll compress down. And so that works. I mean, depending on the gear that we have to be clever. Another thing that I often hear about is that putting it on with bloody hands or anything like that. I tested that in a class this last weekend. I was like, hey man, we're doing this wound packing. Let's do some compression wraps with this SWAT T. And I'll be honest I was two-handed, but I was able to completely occlude blood flow just using the SWAT T covered in fake blood, which is soap, which is super, super slippery. And it was fine. I was okay with it. I'm going to do some more testing, but just to kind of bust those myths for myself. Like, it doesn't matter to me if other people believe it, because I want people to test things themselves. But for me to bust that myth that I had long held to, it was pretty eye opening.
Yeah, I agree. I definitely think the two-handed technique is going to be almost needed for this. The wider the tourniquet, the less pressure it takes to occlude blood flow. You're covering a much more larger surface area on the muscle mass. So it's about 3 inches, I believe, if I remember correctly. So it's got plenty of width there, and to compress that muscle mass. And it doesn't really hurt. Like if you put a cat on, like a cat hurts, soft tea hurts. You can put the Swat Tea on, you're like, oh, that doesn't hurt so bad. But it's still a tourniquet. You can definitely tell it's there. And you mentioned the dogs before too. That's one of the things I push for. Maybe the people are using their dogs for search and rescue. Maybe they're hiking with their dog. The dogs their legs are shaped like a triangle. They kind of come down. So if you use your typical tourniquet, it may want to slide down their legs. It may not be as easy to put on, but that Swat Tees is a compression bandage. Their arteries are really close to the surface. So if you have a dog that you're out in the woods with, or you're using it for working, then it makes a great tourniquet for them.
Yeah, and they're pretty inexpensive too. What do those run?
They're about $15, something like that, if I remember
Yeah.
correctly, right offhand.
I just bought a couple from Medical Gear Outfitters and got them in, and I've just been messing with them kind of nonstop. I've been really mistreating them, just trying to figure out, when do they fail? When do they break? What are they good at? What are they not good at? And the pain factor, it's something that I noticed almost immediately. I was like, okay, this is way less unpleasant. And again, I'm not saying this is like the be all end all. There's no real mechanical advantage, like you have with a windlass or anything else like that. But man, I don't mind them. And they're so good, especially you mentioned pressure bandage. Like, oh, you don't need it to be a tourniquet. You just need it to hold a wound packing in place, or, a SAM splint, or just something else. They're pretty great for that. So I'm kind of rethinking my ankle kit. I might just replace my Israeli style with SWAT T and have something pull double duty.
Yeah, like you said, this isn't the end all be all tourniquets. It's down on my list for what I would use first. But it's definitely an option out there, and I've beat the crap out of them. Like my kids love them. Like they play with them, they run around with them. I've got several that are all faded. That the lettering on there, the instructions that are printed directly on the SWAT T, is completely gone. But it would still work. So they're old. They've been abused. They still have some stains on them, but they're still functioning.
Very cool. And you can find your very own at medicalgearoutfitters.com. You can use coupon code civilian medical. That's the place that I get all my medical gear. And it just so happens that that's your place, right?
Yeah, it just so happened I'm the owner of Medical Gear Outfitters. So if you guys go buy some stuff, my wife doesn't beat me, so I would appreciate it.
But you like to fight, so it's not really a big deal either way, right?
It is. It is.
You're like, she's better than me at it. I love it. But yes, medicalgearoutfitters.com is the place. Civilian Medical is the code. And I would also highly recommend check out Skinny Medic on YouTube. Tell them a little bit about your YouTube channel. Like we've talked about it, but I don't think we've talked a ton about it yet.
So I started my YouTube channel about 7 years ago, something like that, a while back. A friend of mine who was doing gun reviews said, "Hey, I think it's something you should look at and be kind of fun." So we started doing it. We kind of did it off and on for a while. And then several years ago, we got serious about it and started posting 1 or 2 videos a week. And the channel's growing. And what we do is we post videos that are directly related to what you guys are listening to. It's geared towards that civilian first responder. There's EMTs and paramedics who watch it, but we get a lot of gun guys who watch it. We get a lot of people who want to be more prepared, the preppers or survivalists that are watching it. So just being more prepared, we'll throw in some like gear reviews or maybe a gun review, just trying to draw in that crowd. But we're going to talk about tourniquets. We talk about chest seals, everything we went through the March algorithm. We cover in class and kind of get to see it demonstrated, the wound packing or how a tourniquet looks. Because let's face it, your stuff is expensive that you're buying. The cat tourniquet is expensive, the combat gauze is expensive. So why not be able to watch a video and see how it at least looks out of the packaging? I know guys who didn't realize there was 2 seals for the Israeli. They're like, I didn't realize there was 2 packages on the Israeli till you opened it up. So let me open up stuff. Let me show you on video how to use it. That way you at least have an idea of what you're facing when you go into it. And then, obviously we want you to take a class to get some hands-on training. And then, but at least now you have some kind of foundation that you're not completely shocked when you go into this class.
Yep, 100%. And you can find that at youtube.com/skinnymedic. It's my favorite medical YouTube channel. And I watch every video that you put out.
You're bored.
I know it's a secret, but don't tell anybody. But yeah. So yeah, you can find all that there. medicalgearoutfitters.com, coupon code civilian medical. You can find us at civmedical.com. That's our link to the Firearms Radio Network, which is an awesome place to find, gun related podcasts, off-roading podcasts. Now we've got medical podcasts. And I also host another show on there. It's kind of like Howard Stern of the gun world style stuff called We Like Shooting. And go check all that out. We really appreciate it. You got anything else before we get out of here this week?
I was gonna say I got top fan on We Like Shooting on Facebook. I was like, how did this happen?
Literally,
so I don't know how that works out, but yeah, I was like, I got a notification. I'm top fan of We Like Shooting. I was like, I didn't even realize I was liking that much of their stuff.
It's so great because I literally the next day after you sent me that, I became a top fan on Skinny Medic's page.
Nice.
Yeah, it's great. It's I don't even want to say what it is. That's for that other show that I host.
That's awkward. I was gonna say, are you gonna at least take me to dinner first, or what's going on here?
Yes, I will in Indianapolis, where we'll hope to see all of you at the Firearms Radio Network meetup, April 27th, 6:30 p.m. at Sun King Brewery. And Dietrich, I'll talk to you very, very soon when we do our next episode.
Yes, sir.
All right.
Find us and subscribe at civmedical.com.